Good afternoon, and thanks for the invitation. I will try to keep you awake in this postprandial time, and also with a topic that probably not many want to touch, but I'm happy to go ahead. I will just start with methodology, if it would start. Okay. So I will follow for part in this presentation of the definition, what you mean as safe, the methodology that we should use and result, and also the context in which the issue of safety has to be framed in. So first about definition. Yesterday I looked at, since I'm not an English mother language, at the definition of what is safe. And what is safe seems that something that protects from a danger or a risk. So the definition of safe intrinsically contains the definition of risk, which you see here, is the possibility that something unpleasant will happen. Of course, during our life, a lot of unpleasant things can happen. And therefore, to know what is safe or not implies the concept of a reference or control. So if we look at the methodology that we use to judge whether something is safe or unsafe, as I said, we need controls. So in other words, we need control studies, or at least an incidence within a certain period of exposure, perhaps 5 years, and possibly long terms, because some adverse event tends to happen after a certain incubation time, or they are progressively increasing over time. We don't have many control study. We have, but the issue here also that the data are less abundant than we think they could be or they should be. So one first issue is to get the incidence versus the rate concept. So incidence means mostly that after a certain time I had so many side effects. You can describe, for example, the number of adverse events over a certain amount of time, and depending on the type of patient you are. Or you can compare different drugs and see what type of side effect you observed over time. But the best measurement of it should take into consideration the exposure time, because if I have 10% after 1 year, is not 10% after 5 years. And so the best way, I think, is the way that is presented here for bosutinib and cardiovascular side effects, to have a control, so a control study where you have two groups of patients that randomly were assigned to different treatment, and where the side effects in terms of vascular or cardiac adverse event have been measured over a quite long period of time, because the phase 3 BALA study had a 5-year medium follow-up, and expressed as number of incidents per person 100 years. So that allow you to see numbers that are definitely comparable in the two groups, and which show to have an incidence and a rate of adverse event that is quite similar in the two groups. So this is, if you want, is the most controlled situation in which to say whether something is safe or is not safe. But sometimes we cannot afford this type of detailed and controlled information. So we have to rely on a set of data that are less, if you want, exact. I took this nice review from Bruno Madeiros that was just published in Blood Reviews recently, and I will go through the different inhibitors and try to comment on those. So, for example, if you look at imatinib, there is some signaling of cardiac dysfunction or insufficiency. However, if you look at that, their numbers are quite similar to those observed in the Framingham heart study. Just to say that because cardiac insufficiency is a common phenomenon, especially in people after a certain age, the numbers you see are not linked to the usage of imatinib, but are rather linked to the age and comorbidity of the patient. And indeed, as you know, imatinib remains the most tested and safe TKI used up to today. If we look at the second inhibitor, which here is dasatinib, then with dasatinib, the issue is certainly the one of pleural and pericardial effusions that have been turned out to be composed by mostly CMV reactive lymphocytes that probably are caused by a reactivation of CMV caused by dasatinib. And the issue here is that the numbers are not low. Over a 5-year period, 28% of patients experience these side effects, but also that this effect is incremental over time. And so if you continue to treat patients with dasatinib, the number of patients that experience pleural effusion tend to increase. So this is something, of course, to bear in mind. The third compound has been listed in this table is nilotinib, and for nilotinib there is one problem related to its, let's say, metabolic effect, which this is really surprising, are almost the opposite of the ones that have been described for imatinib. So while imatinib tends to decrease glucose and lipid values, at least for the first 2 years of treatment, nilotinib seems to be doing exactly the opposite. Lipids value and cholesterol level tend to increase, and this accelerates the onset of atherosclerotic lesions. It's not really clear if this is due to a different ratio in the inhibition of imatinib versus nilotinib. Imatinib preferentially inhibits PDGF receptors, nilotinib preferentially inhibits Abelson, or because of some different and still not very well known hit of different targets by nilotinib and not by imatinib. Another phenomenon that's been observed related to nilotinib is that also the glycemia of patients tend to increase with a differential of about 20% compared with imatinib, and with 7% of patients that have a severe glycemia, because a 3-4 grade glucose level means a glucose level over 250. These metabolic effects then are translated into less nice effects that are mostly cardiovascular events and the development of diabetes. However, while diabetes is definitely reversible with discontinuation of nilotinib as the glucose is, the cardiovascular events are not reversible, and so in my opinion these are the adverse events you have to be more wary of, because once they develop, there is no return to normality. With bosutinib, I already showed you the comparison to imatinib in terms of cardiovascular effect. I will point here that bosutinib is associated also with pleural effusion, but with values around 4%, definitely lower than dasatinib. However, also with bosutinib, this effect can develop after a long period of treatment, and therefore this has to be taken into mind. It's also true that, especially for what pertains to bosutinib and ponatinib, we still know relatively little about them. They have been on the market since a relatively short period of time. There are not many patients that's been treated with them, and therefore we need to be very careful. For example, we noticed in bosutinib-treated patients a certain number of patients with quote-unquote autoimmune problems. We are, of course, investigating those with Pfizer, as any researcher should be when they find something unexpected. The last inhibitor presently approved for in the market is ponatinib. I'm sorry, I did not mention radotinib, which is approved only in Korea, but that is very similar to nilotinib in terms of adverse event. Ponatinib has the main basic problem of increasing blood pressure in the majority of patients that go on it. The mechanism of it is probably linked to the inhibition of VEGF receptor, which ponatinib blocks, different with other compounds. And this effect turns into a percentage of patients that experience cardiovascular events that's not low, and that in some studies went to the 30% level. It's also true that as we advance in our knowledge and experience with inhibitors, we became a bit more able to, for example, use lower dosages of ponatinib, and this hopefully will decrease this type of effect. It's also worth to mention that there are in clinical trials some molecules that are, if you like, derived from ponatinib, but are devoid of VEGF receptor inhibitory capability, so that could maintain the activity on the 315I mutation, for which ponatinib is uniquely active without having the cardiovascular component. It's also important to note that cardiovascular event of ponatinib can occur also in a short period after the initiation of this drug. The final consideration I want to make is about the context in which we are working. I think it does not need to be remembered, perhaps only to the youngest people, that we are no longer working in this world, but in this world. The prognosis of our patient is much better than before imatinib was developed, and therefore we need to be very careful in terms of risk that we expose our patient to, knowing their excellent prognosis that they have, especially when we deal with a patient treated in first line. So in conclusion, I would say that not all TKIs are equally safe. Imatinib represents the TKI with the highest number of patients treated and the longest follow-up available, so that's therefore the TKI for which we have most of the data. I would be very cautious about the irreversible adverse event of some TKIs, especially when used in first or second, because the prognosis is still quite good use. Especially the use of a toxic TKI must have a clear and strong rationale. And since I know that all the presentation that will follow are dealing with second generation TKI used in first line, I would be very happy to understand what's the rationale behind this huge. I will close to just showing you two pictures that I saw yesterday arriving in this city, which I think epitomize a bit our role. Our role as investigator is the one of seeing a situation that can look a bit less clear and not very detailed and a bit murky into something that is much more clear and visible. Thank you.
Thank you very much. Any questions for Carlo?
As usual.
It's very, very clear.
I have one quick comment. Doug Smith from Baltimore. I think the worst toxicity or the worst outcome from any of these drugs is to not respond to therapy. And I think that's the tricky part of the balancing, the potency of drugs and the side effect profile as compared to just thinking about the side effect profile long term, because that's one of the main goals is still to get the best drug that someone will respond to, then give it to them in the lowest and best tolerated dose. So I do think that that is one of the things that we need to keep weaving into this equation.
In general, I would definitely agree with you. In the specific, I would remember that there is no proven superiority of any second or third or fourth generation TKIs in terms of PSF or protection from progression. So in that sense, I think safety comes first because efficacy is not different.
So my question is that if you institute primary prophylactic measures for vascular disease on patients with nilotinib right at the beginning, like exercise and weight reduction and lipid control and tight glycemic control, will that prevent the vascular toxicities of nilotinib?
I mean, I'm not a heavy user of nilotinib. Definitely any preventive or therapeutic measure is worth of being implemented. But my question is that, as I say in the conclusion, if I want to use a TKI that's, let's say, linked to some important side effects, I must have a very strong reason for doing that. And the strong reason means, for example, a mutation that is uniquely sensitive to that particular TKI. If I don't have a very strong rationale and I have alternatives that are safer, I would wonder why to embark in this cardiovascular monitoring and treatment if I can just have a safer alternative.
So one more question.
Nice talk. In my vision, every time you use a tyrosine kinase inhibitor, you get apoptosis on hematological cells, and you get senescence on a vascular system. So the vascular system responds to the TKI inhibition, getting senescent accumulation, but not died. They don't die, the vascular cells. So how we can measure these senescence on endothelium, which is probably a stochastic and very long-lasting activity, because it's very easier to account for toxicity and for efficacy for blood cells, because they get apoptosis. But in the endothelia, you don't get apoptosis, you get accumulation of very, very senescent, probably 20 or 20 times more than normal life. So you get very rapid accumulation of senescent epithelial cells. So how we can measure this kind of toxicity, which is quite prolonged in Spain in the time?
I have to admit my ignorance on endothelial physiology. I don't know of any way that you can measure how endothelial cells react to a TKI. I can only think that if you damage endothelium, you will have some consequence that you can measure, like when you hit VEGF receptor. I'm not, for example, I'm not aware of senescence caused to endothelial cell by imatinib, but I could be wrong.
Okay.
Thank you very much. I think we're going to continue with this session. Thank you very much, Carlo.